Okay, this is attempt number 3. Just keep a happy smile on your face and we'll get through this. I probably will divide this up into 2 because maybe that's why it's not recording. It may be a little bit too long. So we're going to try trial number 3. It's all good. So I took all the color out of V1, hoping that this would make a difference. So we're going to see all about the complications in labor and delivery. Okay, preterm labor is one of our biggest complications in labor and delivery. Preterm birth is any birth that occurs before the completion of 37 weeks gestation. So say you had a patient that was 36 and 7, or 36 and 6, excuse me, weeks pregnant, would still be considered preterm. Preterm labor is if you have cervical change in uterine contractions that occur between the 20 and 37 weeks. You should know that true labor, true preterm labor, is going to be cervical change. So that works with term or preterm. SROM, spontaneous rupture of membranes, if it occurs before 37 weeks, it puts the patient at risk for preterm labor. Usually if you're ruptured membranes, you have a lot of irritation down there and your cervix starts to dilate. You can see variable decelerations usually due to cord compression if we have a spontaneous rupture of membranes. So remember that when I told you always check fetal heart tones when membranes ruptures because we're worried about cord prolapse, cord compression. So be sure that you that you would possibly see variable decelerations due to that. We can treat that, of course, our variable decelerations, by doing what? We can increase their IV fluids. We can turn them on their side. We can also do an amnio infusion, and this is when we put in the IUPC, intrauterine pressure catheter. We put that in, and we can actually infuse lactated ringer or normal saline into the uterus to provide fluid for the baby's cushion. We have to be very careful about how much we put in. We have to do an accurate INO of how much goes in and how much goes out. Uterine contractions, if they're 10 minutes or more apart, it could be dehydration. You have a patient that calls in that just has been out in the heat, or it's been very hot today, or she hadn't been drinking very much. You can tell her to drink several glasses of water, lie on her side, and monitor herself for an hour. If the contractions continue to be 10 minutes apart and become stronger in intensity and duration, she needs to come into the hospital. You would rather have her come in and not be in preterm labor than for her to deliver at home. Suppression of preterm labor. Early recognition is essential. We have signs and symptoms that we need to teach our patient about preterm labor. Forgot what I was talking about there for a minute. That's all right. It's been one of those days. We'll get through it. So the things that we need to teach our moms about preterm labor, signs and symptoms, they're on page 783 of your book, under box 33 and 3. And then you can teach them self-management as well. But we really want to make sure that they know what the signs and symptoms are. Back pain is a major symptom of preterm labor, as well as a common discomfort of pregnancy. So if it's coming and going, it's usually being caused by a contraction versus a steady pressure on the back. So you have to be able to teach them the difference between the two. Some of the things we can also do is tocolytic therapy, which is suppression of uterine activity. Usually only delays. We do not have any tocolytic that can actually prevent preterm labor once it gets started. We usually end up having a preterm baby if the patient is in true preterm labor. A lot of times we treat probably more than 50–60% of our patients are really not in preterm labor, but we treat them anyway. There is no chapter 64 in your farm book. That was last year's farm book, and I missed it. I went over all of these PowerPoints, and I was thinking we still had the same farm book we had last year, which we don't. So there is very good pages in your book on about the tocolytic drugs. Starting on page 787, tells you about magnesium sulfate, tells you about terbutaline, prostaglandins, which are your indomethacins, prostaglandin inhibitors, excuse me, and your calcium channel blockers. And those are some of the tocolytic drugs we use. So that will cover those drugs enough that you will not have to worry about doing the farm book, because it's not there. So here's our tocolytics that we do use. These are the commonly used tocolytics. There are some people that do some strange things, but most of the drugs that we use are listed here. Indomethacin is only used for short term. It's an NSAID. It usually doesn't have any problems with the mom, but it can cause some bad effects on the baby, such as pulmonary edema on the baby. It usually doesn't have any effect on the mom. Should not be using it in hypertensive patients because of kidney function or with a patient who has asthma. So you have to keep in mind, if you have a preeclamptic patient that's in preterm labor, you will not use indomethacin. Nifedipine, which is Procardia, is a blood pressure medication. It's used to treat blood pressure. It's a channel blocker, calcium channel blocker. And the actions here is that it's going to inhibit the calcium from entering the uterus smooth muscle. We do see fetal effects with this, and you can't use the Procardia and the mag sulfate in tandem with each other. They cause too much of a drop in the blood pressure. They can actually cause cardiac arrest. So you never want to give these two at the same time. I know this from experience. Fetal effects that Procardia has, you will see because mom's blood pressure gets lowered, mom's pulse is lowered, we see decreased placental flow, we see bradycardia, and of course we see hypoxia because we have that decreased placental flow, so oxygen's not getting to the baby well. Terbutaline is a drug that we used to give for asthmatic patients. This drug causes you to be very nervous, gives you the shakes, makes you feel a lot of anxiety. It's a smooth muscle relaxer, but the really bad thing about it is that can cause pulmonary edema, increased heart rate, both fetal and maternal. So we need to be doing breath sounds often, making sure that we're checking for pulmonary edema, and do not give the medication if mom's heart rate is over 120. We can give this either sub-Q, which is usually what we give when we first start giving this medication. We will give it sub-Q, and we can give it quite often, about every 10–15 minutes until the contractions stop, for about 3 times. But most of the time that we're given the terbutaline, we've got the contractions stopped, and we send them home on PO breathing, and we teach them to do their heart rate. Magnesium sulfate is the most common tocolytic that's used these days. It's also used with preeclampsia patients, and I'll go over with you about the preeclampsia patient when we do hypertension. For preterm labor, it's smooth muscle relaxer, so it's going to decrease mom's uterine activity, hopefully. It also has a side effect of lowering blood pressure, and as you well know, magnesium sulfate is used to treat seizures in adults when they come in with seizures. So mainly we have to monitor the same thing we would monitor with preeclampsia, in that we monitor I&O, we would monitor reflexes and level of consciousness to make sure we're not getting toxic on mag sulfate, which is very easy to do, and we'll go over that toxicity parameters when we go talk about preeclampsia. So some of the things we can do for prevention of preterm labor is antibiotics. UTIs are one of our major causes of preterm labor. Bacterial vaginosis was identified a few years back that it was also a culprit in causing preterm labor. We don't really know the complete mechanisms of preterm labor because with everybody it's different. It's not like we can say, okay, this causes preterm labor, let's fix it. There's a lot of things that cause it, and that's why it's so hard to fix. Hydroxyprogesterone Capret was approved in 2011. It's a compounding drug. It's very expensive, and not very many doctors use it because it's so expensive. And it's usually used in the office as a compounding medication. The doctor has it made up, and then he inserts it into the vagina once a week. So this is usually given to women who are at high risk, like they've had a preterm pregnancy before. So what else can we do? Well, you know that before I said we can't stop preterm labor, but we can delay it. This is why we want to delay it. Usually if we have a patient who's 24 to 34 weeks gestation in preterm labor, they should get glucocorticoids until she is at term or delivers, unless she has chorioamnionitis. It requires 12 hours to be effective in maturing fetal lungs. What this does is that it activates the production of surfactant. So our surfactant level gets up higher in the fetal lungs with giving this medication, but it takes it 24 hours for it to start having an effect. Usually give 12 to 12.5 milligrams IM. You give one, say if you gave one at 12 o'clock on Thursday morning, you would give the second one at 12 o'clock on Friday morning, and then every Friday morning for every week, every Friday morning a week apart, you would be given another shot. So that to keep the surfactant level up until they become term or until they deliver. Fetal fibronectin is one of the best predictors of whether or not a patient is actually going to deliver and is in preterm labor or just having contractions. Vaginal swab will predict 99% accuracy that birth will not occur for at least 2 weeks if we have a negative result. If we have a positive result, it means the baby is imminent delivery, but it could be that day, it could be 2 days from then, it might be a week from them. You might send them home if you get their contraction stopped, but they may be back in another day or two in preterm labor. So it's going to be inevitable that they'll deliver preterm if it's positive. Dilation to 4 is an inevitable preterm birth, and we normally do not try to stop preterm labor that has begun if they are 4 centimeters. Premature rupture of membranes and preterm premature rupture of membranes. Premature rupture of membranes is 1 hour before labor starts, and preterm is if they are less than 37 weeks gestation and their water breaks and they are not in labor. We're really concerned with infection. Check that temperature of 1 to 2 hours. Keep your nose out for the odors. Can precipitate. Cord prolapse, we've talked about that. Anytime you have premature rupture of membranes and labor hasn't started, it usually means that our head is not well applied to the cervix, and we can place our patient in a knee chest position to prevent that. Teach her not to put anything in the vagina. We may be sending these people home with premature rupture of membranes if they don't preterm premature rupture of membranes on bed rest if they're not having contractions. Most likely they're going to be in the hospital setting because we'll be giving antibiotics if we start running a fever. And why are we doing this? We're trying to prolong and give this baby more chance for his lungs to develop. Just a few hours makes all the difference. So we're going to do the betamethasone, try to get the lungs mature, and our babies have a much better outcome. We teach them how to do the fetal movements or the daily kick counts. Again, remember that the policy is whatever the policy, the method is always the policy of the hospital or the doctor's clinic or whatever. They should be moving at least 10 times in 12 hours, at least. So, dystocia, of course, is things that are not going well. There's something dysfunctional about them. So things that can cause labor dystocia is cephalopelvic disproportion, pelvic dystocia, soft tissue dystocia. Cephalopelvic disproportion means the baby's head is bigger than the pelvic outlet. Your pelvic dystocia, if you'll remember, we talked about the different types of pelvics and the platypoid pelvic, um, and all the different types of pelvics. And some of them are more prone to cause prolonged labor than others. A long, difficult labor and a dysfunctional labor can be caused by the long labor, can be difficult labor, can be caused by that OP position of the fetus, which is our most common malposition. Usually we'll see a lot of back labor. We can put her on her side, ambulate her, and put her in the chest, get that baby to move. Hypertonic uterine dysfunction and hypotonic uterine dysfunction are really bad things. A hypertonic, well, hypertonic is not so bad, because hypertonic is where our contractions are just not ripening our cervix. They're just not causing our cervix to dilate. They're just not working. So we can augment those with some Pitocin and get them to where they are functional. Hypertonic uterine dysfunction, on the other hand, is very detrimental to our fetus and to our uterus. It can cause uterine rupture. It can also cause fetal hypoxia, because remember, if we're having a contraction every minute, how much oxygen is our baby getting? If we're not having a very good resting tone, how much oxygen is our fetus getting? So that it's really detrimental to our fetus. And with a lot of all that pressure and contracting of the uterus can actually rupture. Our most common malpresentation is breech. There's several different types of breech. The frank breech is usually the one we deal with the most, and you might see some vaginal deliveries with breech. Breech babies usually end up with can end up with Erb's palsy, because it's very difficult to get the babies out via vaginally or abdominally, because you are pulling them from their buttocks through a small area. And even though you're not pulling, if it's vaginal delivery, it's a lot higher risk because it goes through the vagina, and the shoulders are damaged in there. You can see where the baby's right arm has some damage done to it, and you can see how it's extended out. Most babies usually are laying in that flexed position like a frog, and this baby can't assume that position. This is really a costly litigation issue, because the parents can sue for this baby's condition until the baby's 18, 21 years old. So the mark on the arm looks a lot like the forceps marks that you'd be seeing. You see it's kind of like a C shape. So that would kind of be what I would be thinking. They probably had to use high forceps to remove him from being out from a breech presentation. So, different modes of labor. Precipitous labor is your labor that when it begins and ends in less than 3 hours. So from the time it starts to you deliver, 3 hours or less. Version is where we will try to convert the baby from being in a breech position or a transverse position by bringing them into the hospital, giving them some terbutaline or some a little bit of megasulfate to get the uterus to relax, and then turn the baby, and this is very hard to do, but turn the baby to where it's in a head down position. 50% of the time it works, 50% of the time it doesn't. Usually when it works the best is if you can convert them over and then rupture their water and maintain them in that position and deliver them. If you convert them over because you don't want to do a C-section, but you're not going to deliver them until the next week because they're not quite term, the baby is very likely going to resume his breech position. We have trial of labor, induction of labor, and augmentation of labor. Trial of labor is where we just bring them in as an outpatient, say, let's see if you're ready, if your cervix is ready to go through labor. Especially do this with maybe multips, because if they're not ready, nothing's going to help them. So if they don't start showing cervical change within 2 to 3 hours, they are taken off the oxytocin and discharged home. Induction of labor, they're coming in for some reason to be induced. We try to make sure it's 39 weeks or more. We're hoping for 40. And the only reason they can do inductions at White River is the fact that there has to be a medical condition, and that's the way it is throughout. A1 has campaigned for this for a long time. Augmentation of labor is when they come in, they're having good contractions, they dilate up to 3 centimeters, and all of a sudden their contractions kind of fizzle out and they're not going anywhere. So augmentation of labor is where we're giving them some oxytocin to help their labor to come back and be stronger, but they were already in labor. So that is how that condition works. This doesn't really, all of this does not pertain to cervical ripening, but there are cervical ripening agents such as your Cervidil. Cervidil is, they come in at the night and the night before their induction. Cervidil is placed in their cervix and then removed at about 3 in the morning, and then Pitocin started at around a couple hours later. We can also put Lamisol, which is just seaweed sticks. Help assist put 40 sticks in one time. You can use the bulb of the Foley catheter by placing the bulb in and blowing it up to help do cervical ripening that way. We can also help start labor by doing, if they are needing augmentation of labor, we can do artificial rupture membranes, and sometimes that will get them started back. It can also help if we do artificial rupture membranes, bring the head down to the cervix and help the cervix start effacing out and enlarging. Oxytocin, of course, is our drug of choice for any induction. All facilities all do it different. White River does it every 15 minutes, increasing. White County and NEA does it every hour. Forceps delivery is a surgical delivery that's usually done as very seldom. But when it is done, you want to have a doctor that really knows how to use those forceps. They look like big salad tongs. They go in on either side of the baby's head up into the vagina, into the birth canal, and then they're clamped together just like you would a salad fork, and the doctor pulls the baby out. It's usually done when you have epidurals and the mother just cannot push through that epidural. It's really too strong of an epidural, or she's worn herself out trying to push, and the baby's just not far enough down to use a vacuum assisted delivery. The vacuum extractor is preferred over the forceps delivery, but the baby head has to be so far down in the birth canal to be able to use it. This is just a little plastic suction cup, and either the doctor or the nurse handles the equipment that does the suction, and they can only take it up to a certain pressure, and you'll only put it the suction on during contractions when you're trying to assist pulling the baby out. After the contraction's over, then the vacuum has to be released. VBAC is a vaginal birth after cesarean. Vaginal birth after cesarean, of course, was a big thing a few years ago. Now it's not quite such a big thing because doctors are required to stay in-house with them. Anesthesia has to stay in-house with them. Surgery crew has to be right there in-house available, and most rural hospitals do not have all this. Someone like UAMS could do this easily because they have all the doctors there 24/7. Stripping of membranes is another way to try to start labor. The patient goes to the doctor, puts her up in the stirrups, and during the vaginal exam, he uses his fingers to strip the membranes of the uterus. He strips on the outside of the uterus, trying to loosen the amniotic membranes away from the uterine wall. It's very painful, very painful. They think they're in labor right as soon as they leave the doctor's office and come right over to OB. I'm having contractions. Usually, if they are, it's going to take a while for it to work. 42 weeks post-term pregnancy. Up to 42 weeks is still considered term. Things you're going to see in a post-term pregnancy, you may see maternal weight loss. The uterus is going to start decreasing in size. You're going to see possibly meconium in your amniotic fluid because the baby is matured and the anus is matured, and therefore he may need to release meconium. out of his stomach to make room for some more meconium. So you need to be prepared with that laryngoscope and your meconium aspirator. And we'll talk more about meconium aspiration when we talk about the babies. That fetal skull is going to get really hardened, and it's going to make it a rough delivery for mom because there's not going to be any give in the fetal head as it's coming down the birth canal. It's going to make it hard on the baby because he's not going to be able to, the sutures are not going to be able to overlap and make the head smaller to fit in through the pelvic. So it's really pretty rough delivery that way. They're susceptible to postpartum hemorrhage. Babies get shoulder dystocia usually if the babies are still growing, and they'll be have peely skin. They'll be so dry it'll be like they're almost crackled, and they're wrinkled terribly all over. They're at high risk for hypoglycemia. We need to be watching those babies for that. And keeping an eye on them, just because if they're post babies, they're still at risk. In fact, they're at more risk than just a regular term baby. They've had an aging placenta. They've not been able to get rid of toxins sometimes. My sister-in-law, when I was very young, had her first baby. No, it was actually her second baby. And she went to 44 weeks before they finally decided to induce her. And she had absolutely no amniotic fluid, and her placenta was really teeny tiny and calcified, and the baby had seizures. So you really have to watch those sort of things. And of course, they can always do the meconium aspirate syndrome. I'm going to stop recording right here and make a part 2 just to make sure that this is going to record, if that's okay with you guys. Well, even if it's not okay with you guys, I'm going to do it because this is my third go around, and I'm just not whoops. I hate this new machine, or new system, because I can't always find what I'm looking for. Okay.